All right. Good morning, everyone. Welcome to the Antibiotic Awareness Week activities. Today, we're starting off with our first lecture of the week. We're going to have multiple presentations throughout the week at 9 a.m. most days, starting at 9 a.m. Thank you for joining us. So in the spirit of the World Antibiotic Awareness Week, we have developed a lot of presentations focusing a lot of topics that are really necessary for practical patient care. So today, Dr. Hajar Al-Gahtani is going to present a presentation about vancomycin and aminoglycosides, focusing on dosing in adults. Dr. Hajar is an infectious disease clinical pharmacist and working heavily with us in the antimicrobial stewardship program. So please, I hope you enjoyed the presentation. Dr. Hajar, the floor is yours.
Thank you, Dr. Noor. Good morning, everyone. Thank you, Dr. Noor, for the introduction and for giving us the opportunity to participate in the webinar of the first Antibiotic Awareness Week lecture series. It's great to be here and to kick off this week with such a very basic yet evolving topic, such as vancomycin and aminoglycoside dosing. I have nothing to disclose. So let us get started. Today, we're going to review vancomycin and aminoglycosides mechanisms of actions and spectrum of activity, and then we'll discuss the pharmacokinetic and dynamic of both antibiotics. After that, we will evaluate the pharmacokinetic and pharmacodynamic indexes and the preclinical and clinical studies. And finally, we're going to explore the different dosing recommendations and we'll shed the light on the newest dosing recommendations. Starting with vancomycin, which I would say it's a dear friend of GHA, at least here in Riyadh. According to our entire biogram, which indicates that the prevalence of MRSA ranges between 35 to 50% among our adults and pediatric patients admitted into NGHA Riyadh in 2019. So what does this really tell me? It tells us this tells us that the chance of acquiring MRSA is at least 35 to 35% in our critically ill patients, whether adult or pediatric, and more than 40% for patients in medical floor, as we can see here in this chart. And therefore maximizing dosing and targeting higher trough level accordingly whenever you have Staph aureus on the pathogen differential list. Vancomycin is a large bactericidal glycopeptide antibiotic that binds to the D-alanine terminal on the peptidoglycan side chain, which is the main component of the cell wall and the gram-positive organism, which gives the thickness for this organisms, and therefore prevents the elongation of the peptidoglycan chain and interferes with the cross-linking by preventing the penicillin binding protein from cross-linking these D-alanine subunits together, and therefore eventually cell lysis and cell death. Vancomycin has activity mainly against the gram-positive, including aerobic and anaerobic. Aerobic organism including Staph aureus, MRSA, Streptococcus species, and Enterococcus faecalis. For the anaerobes, including but not limited to Clostridium species and Actinomyces. Understanding the pharmacokinetic properties of vancomycin is very important to help us. That really helps us to design appropriate dosing regimen. In this slide, we are going to discuss the pharmacokinetic parameters based on the data driven from general population. Starting with the volume of distribution, which reflects the vancomycin distribution, which is usually equal to 0.65 liter per kilogram, up and down according to patient-specific factors. As we can see in the obese patient, it can go down to 0.4 or 0.3. It can go up higher to like 0.7 and even 1 in overhydrated patients or patients with septic shock. Tissue distribution is almost 50%, and including the lung tissues and inflamed meninges. Protein binding also has ranged between 10 to 50%, and this is really important to keep in mind whenever you have patient with increased plasma protein, like obese patient. You would anticipate that the free plasma vancomycin concentration will be lower in those patients. For the elimination, vancomycin is eliminated mainly via renal system, and the half-life, there is 2 half-lives. For the alpha distribution phase, the half-life is almost 1 hour, followed by the beta elimination phase half-life would range between 6 to 8 hours, considering that we need 1.5 half-life to get from peak to trough plasma concentration, and this will help you to design the frequency of your dosing. Here are sophisticated equations that we mentally memorize as a clinical pharmacist to guide us while dosing vancomycin. Vancomycin clearance is different than the patient's creatinine clearance. The vancomycin clearance is a factor, as we can see here, of the elimination rate constant, which really, with the symbol Ke here, which reflects how fast or slow patient is going to clear vancomycin. And also is a factor of the volume of the distribution that we discussed in previous slides. We can see here different equations to calculate the elimination rate constant based on patient's factors. Like for young patient, we have different equations than those patients with comorbidities and obese patient. Generally speaking, the vancomycin clearance is a factor of 0.65 of the creatinine clearance. Once we figure this out, we estimate the total daily dose by multiplying the volume distribution and the concentration, desirable concentration that we need to achieve, which is 10, like it can range from 7 to 10 or 10 to 14, utilizing the units that we follow here in National Guard, which is the micromole. And then we're going to estimate that half-life and the frequency, dosing frequency based on this equation after calculating the half-life. I have this slide here for the sake of completion and just to present that based on the previous calculations I mentioned, the previous slides and data driven from general population, we came up with these dosing recommendations that we followed and that we follow on daily basis. But remember that this is not patient specific. So now we will dive into deeper level of evaluating vancomycin pharmacokinetic in selected patient population, where vancomycin dosing is usually considered a real hassle. We'll start with the obese patient, which defined as patient with a BMI of more than 30 or weight more than 100 kg. We usually tend to both over or underdose those patients due to the lack of well-established dosing strategies that targets those patients. And I believe by understanding the changes in vancomycin pharmacokinetic, this population is really helpful to design appropriate dosing regimen. Looking at these three pharmacokinetic parameters that changed dramatically in obese patient, starting with the volume distribution here. Volume distribution is theoretically supposed to be increased, secondary to increase in the water content in adipose tissue. However, based on different studies that we were able to evaluate, the volume distribution in obese patient can reach to 1 liter per kilogram in relation to the ideal body weight. However, when you relate it to the total body weight, it goes down to 0.3 and 0.4. So theoretically, you might need a lower doses than 15 milligram per kilogram to achieve the concentration you're looking for or looking to achieve. Moving to the protein binding here, obese patient have higher level of alpha-1 acid glycoprotein, plasma protein, and this would definitely affect the free plasma concentration of vancomycin and make it lower. And the last pharmacokinetic parameter that changed dramatically in obese patient is the vancomycin clearance. So as we can see here, that the ratio of vancomycin clearance in relation to the creatinine clearance in the obese patient is higher than other adults. So it's a factor of 0.9 if you utilize the total body weight to calculate the creatinine clearance, or a factor of 1.2 if you're gonna utilize ideal body weight to calculate creatinine clearance. This is those ratios consider higher than the previous one I mentioned, the previous slide, in the general population, where the vancomycin clearance is a factor of 0.65. 0.65. So obese patient might need lower doses, however, more frequent dosing to achieve the higher trough concentrations. My advice here for practitioners to try not to exceed 4 to 4.5 gram per day. You might need to adjust your doses to be lower than 15 milligram per kilogram, but you might need more frequent dosing if you have like a young obese patient or middle age with a severe infection. What about elderly patients? Those group of researchers in France were interested to evaluate the vancomycin pharmacokinetic in elderly patients, and they found that the vancomycin clearance is significantly lower on those elderly patients aged over 80 compared to the general population, young patients. Volume distribution was quite close to the volume distribution of the general population. So you can see the difference here is like 0.1. For severe infections, you might need to end up like utilizing aggressive dosing regimen to attain a trough level of 7 to 14. However, if you're dealing with elderly patient can accumulate vancomycin rapidly on day 3 to day 5. So, which required frequent monitoring of the trough levels, and then maybe you end up starting with the Q12 to treat this like severe MRSA bacteremia or endocarditis, but after repeating the trough level, you might see like an accumulation, and then you need to shift from Q12 to Q24. So Q12 might be appropriate at the very beginning for elderly patient to treat severe infection. However, you need to adjust it maybe in day 3, after day 3 to Q24. And burn patients, and found by Dalton, burn patients have higher vancomycin clearance. As we can see in this chart on the left side, that vancomycin clearance is significantly higher than control patients. And usually we get around this, so it's very hard to achieve high trough. We usually utilize higher doses, frequency, like more frequent dosing, like we reach sometimes Q6. So another way to get around it is like to administer vancomycin as a continuous infusion, which might improve and increase the likelihood of achieving the target concentration without increasing the nephrotoxicity, as you can see here in the chart on the right side. This is the comparison between utilizing continuous infusion vancomycin and intermittent infusion. We usually target 20 to 30 to 25 milligram per deciliter random level after 24 hours of starting vancomycin continuous infusion. And you can see here that the majority of patients were able to achieve this concentration with a lower nephrotoxicity compared to the intermittent infusion. Vancomycin pharmacokinetic, the major goal of studying the pharmacokinetic of each antibiotic is to establish the pharmacokinetic pharmacodynamic target or parameter that's required to achieve an effective antimicrobial therapy or killing activity. It's really important to realize which MIC you're dealing with which bug. So when we speak about vancomycin, it's usually Staph aureus. So the breakpoint is 2 microgram per milliliter. So MIC less than or equal to 2 for Staph aureus would be considered vanco susceptible. The minimum effective concentration is 10 microgram or 7 micromole by the unit that we utilize at our hospital, and this concentration has been driven from studies that indicate that trough level or around or like a vancomycin serum concentration lower than 10 microgram or 10 or 7 millimole is associated with increased vancomycin resistance after exposure to vancomycin concentration under or lower than this concentration. In these studies, the initial isolate, Staph aureus isolate, had an MIC of 1, and then upon exposure to subtherapeutic levels, the organism was able to develop resistance, and the MIC increased to 3 and 8 after over 72 hours of this suboptimal exposure. They found also that the Staph aureus isolate that has the ability to increase the vancomycin MIC has AGR or agar gene, so it's already mutated isolate. But this is really important to realize that whenever you have patient with a trough level is less than 7 or less than 10 microgram, it's very important to adjust your dose to prevent development of resistance. So the next step after addressing the pharmacodynamic concept is to find this relationship between pharmacokinetic and pharmacodynamic. So usually we start with identifying which pharmacokinetic pharmacodynamic index that would correlate best with the killing activity in vivo. So we have time above MIC, area under the curve with reflexive exposure, the total exposure between different dosing above MIC, or the maximum or peak to MIC, which means the peak concentration or the maximum concentration achieved in relation to the MIC. And then we will determine the magnitude, so which value of this PK/PD would correlate with the bactericidal effect. So trying to identify this pharmacokinetic pharmacodynamic parameter that would best describe vancomycin killing activity against MRSA, we see here in this neutropenic thigh model, as you can see here, that researchers try to study the behavior of vancomycin killing activity utilizing different PK/PD indexes. And according to the determination coefficient, which is R2, you can see that the best PK/PD index is the area under the curve 0 to 24 hours in relation to MIC of above 400, and also followed by time above MIC, which is a trough level more than 15 or more than 10 micromole. And we've been now since 30 years utilizing this trough level as a surrogate marker for this AUC MIC of more than 400 for treatment of MRSA infections. For this slide, I just want to discuss some major considerations that we do really need to keep in mind while prescribing vancomycin. Safety is a big thing. So we get trough levels to avoid nephrotoxicity. Nephrotoxicity is a real deal with vancomycin. It can reach up to 50%. There is certain risk factors are associated with increased risk of nephrotoxicity, including total daily dose of more than 4 to 4.5 gram per day, definitely elderly patient, high trough levels. So every time we target a level of 7 to 14 for MRSA, we are increasing the odds of nephrotoxicity by 3-fold. Another study indicated that every 1 milligram per deciliter above 15 milligram per deciliter is associated with increased nephrotoxicity risk by 13%. So even when we're going to, while we are dealing with the MRSA infections, we keep at the back of our mind that we are exposing patients to risk of nephrotoxicity. So keep monitoring the patients, more frequent monitoring of the trough levels, serum creatinine, urine output, BUN is very important on daily basis. Trough levels should not exceed 7 to 14 micromillimole. And this is for MRSA infection. Autotoxicity is usually associated with a high serum concentration, and we have some data on elderly patients, but the prevalence of autotoxicity is lower definitely than nephrotoxicity. Redmond syndrome is something to think about, to keep in mind while infusing vancomycin. Always try to maximize the infusion rate, so 1 gram should be infused over 1 hour, not less. For the efficacy, we know that vancomycin is a time dependent, and loading patients or administering loading dosing to your patients is very important, and we're going to discuss this in subsequent slides. Maintain your trough level above 4 to 5 MIC to prevent the resistance and also ensure the killing activity. And also, as I said, ensure the trough level is more than 7 for any patient. Every time you use vancomycin, your trough level needs to be above 7 micromillimole to avoid development of resistance. Recommendations of vancomycin loading dose was made to achieve early therapeutic levels. And it has been established after several studies evaluating the trough the trough level of vancomycin after loading dose, as we can see in this chart here. So in critically ill patient and emergency department patient, in this study they just compare between those two different patient population and the relation between administering and not administering loading dose to achieving therapeutic trough level in 48 hours. And as we can see here, that the black bars reflect those patients who did not receive proper loading dose. We always think about, like, there's some argument, like some people would say that every time you give a patient loading dose, and when we talk about loading dose, we are talking about 20 to 25 milligram per kilogram. So this is a bigger dose than the maintenance dose, which is usually 15 to 20 milligram per kilogram. And the argument they usually make that whenever you load your patient, you're going to increase the risk of nephrotoxicity. Well, according to the result of this meta-analysis, the intention of the researchers was to evaluate the risk of nephrotoxicity associated with loading dose versus those patients who did not receive loading dose. And as we can see here, that those patients who received loading dose had significantly lower incidence of nephrotoxicity with an odds ratio of 0.59 and the p-value unsignificant p-value. So before I end up vancomycin part, I would like to shed the light on the new recommendations for dosing vancomycin. So we're actually saying goodbye to vancomycin trough levels, and we're moving toward utilizing AUC 24 to MIC ratio of more than or equal to 400 to 600 for MRSA infections. So there is a new guideline published 2020 by Dr. Rayback, and there is so many assumptions was utilized in preparing for this guideline. The first one is that we assume that we're dealing with a Staph aureus within a vancomycin MIC utilizing broth microdilution method of 1 milligram. Number two, all the recommendation have been driven from a Staph aureus serious infections only. So we don't have data on the appropriate AUC MIC ratio for Enterococcus or for strep and so on. The third thing that I would like to mention here, that the way of calculating the AUC. You're going with, it's either Bayesian or trapezoidal. Trapezoidal is there's a lot of calculations that you have to do as a clinical pharmacist, and usually some institutions they have their Excel sheet or their equations embedded in their system just to help the pharmacists calculating AUC. Usually you need at least 2 samples. One is the peak, and the other one usually trough, or at least 4 hours after getting the peak. Peak level is usually obtained 60 minutes after ending the infusion. Talking about Bayesian is like you need at least 1 level, because Bayesian is like a software that that rely on the population pharmacokinetics to calculate the AUC of your patient utilizing one level. It's usually trough, and you can get it within the 24 hours. However, the optimal way to calculate AUC utilizing Bayesian is to have 2 levels. So you might have a first level obtained within the first 24 hours and utilize this Bayesian software, but in 48 or 72 hours, you've got to have 2 levels, as I said, peak and another level, which will be at least 4 hours after obtaining the peak, to recalculate the AUC of your patient. So you might end up adjusting the AUC in the first 24 hours based on the Bayesian software you utilized, but might be not necessary when you move to day 2, where the patient is already now in steady state and higher AUC was achieved if you utilize the previous dosing. Patient population that they deemed to be eligible for AUC-MIC monitoring, adults and pediatrics. In pediatric population, we have only retrospective studies, unlike adults patients when we have prospective studies that have already evaluated the AUC. Patients at high risk for nephrotoxicity, like critically ill patients with a stable renal function, or those patients receiving concurrent nephrotoxic medications, and those patients who are expected to be on prolonged course of therapy, like more than 5 days. I would like to mention here that we are working on developing guideline and on to utilize AUC MIC guided dosing for vancomycin, and hopefully this project will see the light in a few months, inshallah. Takeaways: monitoring is very important. Vancomycin dosing is patient-specific. One dose will never, ever fit all patients. Always consider loading dose of 20 to 25 milligram per kilogram with a max of the 2.5 gram for patients with severe infections. Please consult your clinical pharmacist. Never allow your patient to be on vancomycin for more than 72 hours without trough and without consulting your clinical pharmacist. Always look for alternative therapeutic options if your patients failed to achieve the trough goal, and or if patient developed acute kidney injury. AUC guided dosing is our future dosing strategy, so we're just gonna say goodbye to trough levels hopefully soon, inshallah. Now moving to aminoglycosides, which is the second part of this presentation. Aminoglycosides are small, hydrophilic, weak, basic antibiotics, which are bactericidal agents against gram-negative bacteria. It kills bacteria by inhibiting the protein synthesis, starting with transporting across the bacterial cytoplasmic membrane in an oxygen-dependent manner, and then bind to the 30S subunit of the ribosome and induce the conformational change in the A site of the 16 subunit of ribosomal RNA. The resulted protein from this process is it's a corrupted protein and will stimulate a free radical formation and eventually cell death. The antibacterial activity of aminoglycosides enhanced in alkaline pH and an aerobic environment. I would like to mention here that MIC if gentamicin, like the susceptibility is different, so all aminoglycosides might be susceptible to this organism. However, different potency can be manifested by different MICs that each organism can utilize or achieve to kill the bacteria. So for serraceous species, for example, it usually has the lower MIC is associated always with gentamicin. For Pseudomonas, we're talking always about tobramycin, which has the lowest MIC. It's worth to mention that aminoglycosides lacks activity against Burkhalderia sebacea, Stenotrophomonas maltophilia, and Pasteurella maltosida, and has no activity against anaerobes. So as we can see here, the susceptibility pattern of Klebsiella and Pseudomonas species among adult and pediatric patients at NGHA. As we can see here that aminoglycosides, gentamicin still reserve an additional activity against these two organisms compared to the beta-lactams. So why do we like aminoglycosides in ID? Because it's a very old antibiotic, so we have a good experience utilizing it to treat our patients in the clinical practice. It's relatively broad, has a broad spectrum. It is bactericidal and cheap. However, we dislike aminoglycosides for its serious adverse drug reaction and poor penetration. As I said, pharmacokinetics is important to understand the effect of human body on the drug or antibiotic. Is this like a snapshot on the pharmacokinetics of gentamicin? It has a very low half-life, like almost 3 hours. We're talking here about young patients with good creatine clearance. Volume distribution has a very small volume distribution, 0.25. It can go up and down based on specific patient factors. Aminoglycosides are cleared renally, and the CNS penetration is 1% only. As you can see in the table on the right side, that the difference in pharmacokinetic of gentamicin when dosed differently, high dose versus low dose, which we'll discuss in the subsequent slides. You can see the differences here in the distribution and the clearance, which can be explained by the saturation of the transporters responsible for the tissue uptake. So high dose takes a longer time to clear, to be absorbed, and then, to distribute and then to clear. Here are the breakpoints for aminoglycosides for Pseudomonas and Enterobacteria according to the CLSI recommendations, and we can see it's identical. So 4 for Genta, Topra for both, and Vancomycin 16. So this is like really big breakpoints. And would you imagine if you have like an isolate with like an MIC of 3, let's say for gentamicin, I believe it will be challenging to achieve the therapeutic or the goal peak that correlates with the highest killing activity if you have an isolate with elevated MIC. So for macrodynamics, we're focused on gentamicin in this slide. So Tamital studied the killing activity of gentamicin against the Staph aureus, as we can see in the top, and Pseudomonas, as we can see on the bottom here. Starting with the chart on the right side, we can see the gentamicin killing activity of gentamicin killing activity of Staph aureus, comparing between different dosing, like giving 3 milligram per kilogram in 3 divided doses or once daily. Giving more frequent doses appear to be more bactericidal compared to the once daily administration. However, both dosing regimen achieved a substantial killing activity at 24 hours, as we can see here. However, on day 2 and day 3 and 4, the more frequent dose, the once-day dosing enhanced the regrowth. So, because of that, we usually recommend to give slower doses, more frequent, when we use gentamicin for synergism with another beta-lactam to treat Staph aureus, unlike Pseudomonas. Moving to the chart on the right, as we can see here that for the Staph aureus, the bactericidal activity observed was a concentration dependent at lower concentration. So usually the concentration of 4-fold above MIC was enough to achieve the killing activity. Increasing the concentration above that will not correlate with an additional killing activity, unlike the Pseudomonas. So we need to establish a relationship between the MIC that we have discussed and the in vitro behavior of aminoglycosides when it comes to the killing activity. So we can design a dosing regimen. This slide, we're going to just discuss the relationship between the different PK, PD indexes and the change in the number of bacterial population in the thigh of the neutropenic mice. Following the coefficient determination, here we see that the OEC MIC correlates with the highest killing activity, followed by peak to MIC. So this is preclinical studies. What about the clinical studies? As we can see here, Morital was the first to indicate that an increasing response with aminoglycoside was observed when the maximum peak level MIC and the clinical response. For a peak of aminoglycosides level, to MIC ratio of 0 to 1, as we can see here, is associated with a 55% clinical efficacy, whereas a peak of 8 to 10 or above 10 correlate with the clinical cure of more than 80%. So we have a preclinical and the clinical data that tells us whenever you use aminoglycosides to treat a gram-negative bacteria, you need to have to achieve this PK/PD parameter, which is a peak above MIC of 8 to 10. Dosing strategies, I'm not going to spend a lot of time on this. We have two dosing regimen, is high dose extended interval, which I love and I always recommend. And the second strategy is traditional or conventional dosing. We usually utilize this for when we use aminoglycosides for synergism, I mean for a gram-positive based on the in vitro studies results. And if the patient is not eligible for the high dose extended interval. For the efficacy, we just mentioned that Moore was the first one who linked the aminoglycoside exposure to the outcome. Since then, that was like in 1980. Since then, we have more than 45 studies that was mostly prospective, and 9 formal meta-analysis was done since then to evaluate the differences between utilizing different dosing regimen and the clinical cure on nephrotoxicity. 8 found that clinical outcome was improved significantly with a lower incidence of nephrotoxicity with the high dose extended interval. However, when it comes to autotoxicity, it seems to be equivalent or trend toward to lower risk, just in a very few studies. I need to mention here that one of the most important studies that evaluated the once daily dosing, which has been done by Dr. Nicolau and his team in 1995. I'm just going to have like a glance at this slide very quick. They utilize 7 milligram per kilogram for gentamicin with a frequency based on the creatinine clearance. They included more than 2,000 patients with an average dose of 450 for gentamicin. The average age was 46, and they included elderly patients up to 97 years old. The nephrotoxicity associated with this dosing regimen was 1.2% compared to the baseline nephrotoxicity at Hartford Hospital, where they conduct their study, which was 3 to 5%. Diving into different pharmacokinetics in different patient population, an obese patient, I always recommend to use adjusted body weight to calculate the dose. And this French group, they evaluated the efficacy and safety utilizing weight with a correction factor of 40%. They include 31 patients. They monitor Cmax, which is a peak, and trough, and they found that 71% of their patients were able to achieve therapeutic peak level. 5 and 4 patients had supra and subtherapeutic levels, respectively. Nephrotoxicity was developed only in 2 patients, one in the supratherapeutic levels and one in the therapeutic level group. Moving to the elderly patient, this group of scientists were trying to describe the aminoglycosides, the appropriate dosing for aminoglycosides and the nephrotoxicity associated in patients older than 75 years old. They included 148 patients with a mean age of almost 84. Majority received gentamicin, and they found that the gentamicin dose utilized were 4 milligram per kilogram, and for amikacin was 13.5. It seems like that the once daily dosing was their favorite, since 92% received this doses like on once daily dose, and they found that that only 27% of those patients were able to achieve the Cmax to MIC more than 10. So the recommendations for the author from the authors were like to maximize the dose and using 5 milligram gentamicin and 15 milligram amikacin would really help to achieve the peak MIC ratio of 8 to 10. And so don't be afraid to use high dose extended interval in elderly patients. In univariate analysis, they found that the risk factors associated with developing nephrotoxicity was those patients on nephrotoxic medications, and when the duration of therapy is more than 3 days. And interestingly, that those patients who received more frequent doses were at higher risk for developing nephrotoxicity or AKI compared to those patients who had once daily daily dose. When you say once daily dosing or high dose, it means like it can be Q24 or Q36 based on the creatinine clearance. So don't be afraid of using high dose for your elderly patient. Burn patients, it's another interesting population. In this study, French researchers were trying to describe pharmacokinetic of high-dose extended interval of tobramycin in severely burned patient. They included 23 patients, and they found that the peak concentration they were able to achieve was 7.4, which is really low. However, when you see the Cmax or peak MIC ratio was 14.8, that means that the isolates they were dealing with had an MIC, a very low MIC, since this low peak was able to achieve this ratio. Interestingly, the half-life was prolonged, and the volume distribution was a bit higher than general population. So what does this really tell me? High volume distributions will put the high risk of achieving suboptimal Cmax, and therefore, if you're dealing with an isolate with a high MIC, the Cmax MIC ratio will be less than 8 to 10. However, whereas the elimination half-life is prolonged, that means that you're exposing the patient to higher risk of getting or achieving high trough concentration and therefore high risk of nephrotoxicity. So the take-home message of this study that don't be afraid to use high-dose extended interval in burn patient. However, you need to study your patient. It's because you might have like two burn patients that they have completely two different pharmacokinetics. So don't afraid to use high dose. However, you need to follow the trough levels and the random level and follow the recommendation by utilizing Hartford nomogram. Takeaways: monitoring is very important. Please don't allow your patient to be on aminoglycosides for more than 48 hours or 72 hours without obtaining a trough. Aminoglycoside dosing is a patient specific. One dose will never fit all. Please consult your clinical pharmacist and look for alternative therapeutic options if patients fail to achieve the peak goal or develop AKI. AUC guided dosing seems to be our future also for aminoglycosides. So I'm just waiting patiently for more studies to evaluate what is the optimal AUC MIC ratio to deal with different gram-negative infections, because there is no census in the literature yet. And by this, I think my presentation is done. I will open the floor for any questions.
Thank you, Dr. Hajar, for the very thorough, very practical presentation on vancomycin and aminoglycoside dosing. So I know this is a lot of information about PK, PD, and I hope that I know the audience is quite mixed in background and interests. I'll start with one question. What would you say would be the main role for nurses in identifying and monitoring patients on vancomycin and aminoglycoside in terms of understanding trough and peak levels, and what should they look out for when they're monitoring for nephrotoxicity or other toxicities?
Sure. So I always think about nurses out there like they are like front liners. They are there, they're giving the medication, they are like at the top of their game. So we need really our nurses to realize that any patient in vancomycin can develop nephrotoxicity. Like you have to have like a 50% chance that the patient is at risk of nephrotoxicity. Always consult your clinical pharmacist. Always get the trough levels on day 3 or day 4. If your patient is receiving vanco every 8 hours, please get a trough before the 4th dose. If your patient is getting vancomycin Q12, please get it before the third or the fourth dose. Always get it trough levels within 48 hours. If your patient is expected to be on vancomycin for more than 72 hours. I've seen sometimes patients on vancomycin for 6 days, 7 days with no monitoring, with no trough levels. So I do really heavily rely on our nurses to remind the team, remind the clinical pharmacist, get the clinical pharmacist on board and everyone in the medical team to just order a trough level and see where are we. So obtaining a trough level is very important. Identifying the any signs that tells us, hey, this patient is starting to accumulate VANC. So when you see an increase in the serum creatinine, when you see drop in the creatinine clearance, when you see the BUN starting to go up or creep up, if you see the urine output is starting to go down, that's all of these are signs, that alarming signs that really urge you to get a trough level and see where are we, because your patient is probably is accumulating VANC because of the nephrotoxicity.
All right, got it. Great overview of that. So the other question I had here was, what would be an easy way especially for residents and physicians in general, to decide which, I know you mentioned it thoroughly, but as a brief summary, how would you decide if you want to give an extended interval dosing of aminoglycoside, or if you're going to give a multiple daily dosing? Is there a quick way to try to remember which patients fall under which category?
Sure, that's a really good question. So for aminoglycosides, whenever, as ID practitioner, whenever I found myself thinking about aminoglycoside, that's mean I am treating a confirmed infection caused by a gram-negative organism, or my patient is not responding to this big guns like beta-lactam, like tazocine, piperacillin, tazobactam, miro, or imipenem. So I'm usually thinking about a gram-negative. I'm not thinking about a gram-positive now. We know that a gram-positive for synergism, it will be conventional dosing, low doses, more frequent. I'm talking about a gram-negative. In a gram-negative, I always think about the high-dose extended interval. You can give it to everyone as long as their creatinine clearance is above 30. Some institutions go with 40, but we should feel comfortable giving these high doses up to creatinine clearance of 30 or above. If you have, I would not advise to administer high dose for a pregnant lady due to the ability of the aminoglycoside to cross the placenta, like 37% can go to the placenta and then can cause increased risk of autotoxicity to their babies. Burn patients, because of their unsubtle pharmacokinetic, you can start 5 or 7 milligrams per kg for gentamicin, but never say 7 milligram per kilogram Q24. Never specify the frequency. Always urge the team to get a random level, plot it into the Hartford nomogram, and study the pharmacokinetic of gentamicin or whatever your aminoglycosides in your burn patient. Patients with ascites or liver disease, usually because liver disease has been identified as a risk factors for nephrotoxicity. However, I'm trying to get more data on this. I'm not really entirely convinced, to be honest, but I don't have good data to support what I'm saying, but we'll just say that it has been associated with increased nephrotoxicity. What we say, so we said burn, pregnancy, patient with ascites, patients on renal replacement therapy like hemodialysis, patients on CRRT are not a good candidate. However, those patient population can administer high dose extended interval by a different dosing strategy. So I would not touch base on this. But generally speaking, those are the patient population that I would utilize high dose for them.
All right, excellent. So it seems like you're describing patients with changes in volume of distribution, those ones would seem to be excluded from the extended interval dosing. I think we have 10 seconds to answer the last question. We have quite a few, but there was a question about the half-life of vancomycin in patients with renal dysfunction. What would be the half-life in those patients? I guess, would you be able to say that the half-life is the time required to eliminate half of the concentration, to reach half of the initial concentration? So I guess, what would you say the half-life is in a patient with this abnormal renal function?
So it's definitely more than above 6 to 8 hours. So we're talking about maybe, depends on the degree of renal dysfunction. So we're talking about 12 and above. It can be 12, it can be 24, it can be 48, it's somewhere there. But definitely, I would say it's more than 8 hours for sure.
Excellent. All right, so apologies for the questions we couldn't tackle today. Thank you all for your attendance, and I hope you enjoyed and benefited from the presentation. I know I have. I hope you can join us for the upcoming presentations throughout the week. And thank you, and remember antibiotics and use them wisely.